Hello everyone, I'm Stefano Frara, I'm assistant professor at the Università Vita Salute San Raffaele, and I'm working together with my mentor, Professor Giustina, in San Raffaele Hospital in Milan. I would like to thank the organizing committee for this kind invitation, and it's a great pleasure to be virtually with all of you. Today, I'll present how to manage bone complications in patients affected by Cushing disease and acromegaly. We are aware that pituitary hormones play a key role in bone health, acting both directly and through their peripheral effectors on bone cells. Since the clinical management of patients with pituitary tumors is relatively expensive and challenging, this should be performed in pituitary tumor centers of excellence, where the leading units are supported by other specialists. And I hope that at the end of this presentation, we'll all agree that the bone expert should be included in this multidisciplinary team. Specifically, on the diagnostic side, the bone expert can identify the optimal tools among the most appropriate bone turnover markers, since bone loss is determined by an imbalance between bone resorption and bone formation, or when lumbar and hip DEXA scans should be performed and how the results should be interpreted, since T-score, which is usually used for the diagnosis of osteopenia and osteoporosis, must be evaluated only in those that are older than 50 and in postmenopausal women. When we talk about osteoporosis, fragility fractures represent the only ardent point, and they are commonly underdiagnosed, particularly when they are not proactively investigated by assessing a vertebral morphometry. In this clinical setting, the bone expert will also perform a morphometric evaluation with different tools, including X-rays, MRI, or DEXA scans, to detect fragility fractures according to the Genan's classification. Osteoporosis and fragility fractures are amongst the most severe systemic complications in both ACTH-dependent and ACTH-independent Cushing syndrome. And if untreated, they significantly reduce quality of life and life expectancy. On a pathophysiological point of view, we know that glucocorticoids and cortisol per se inhibit osteoblasts and promote osteoclast differentiation and survival. But when in excess, cortisol may cause a negative imbalance of calcium metabolism and determines hypogonadism and GH deficiency, which are all involved in bone health. In patients affected by Cushing disease, bone turnover markers directly correlate with cortisol excess, as shown on the left of your screen, and there is an evident uncoupling of bone remodeling, with increased bone resorption and reduced bone formation. Bone mineral density is reduced both at the spine and at the hip as compared to controls. In addition, we can observe an even greater reduction in BMD in those with adrenal forms than pituitary ones. Nonetheless, osteoporotic fractures frequently occur despite normal or only slight decreased BMD, suggesting that decreased bone strength, mainly due to deterioration of bone tissue, is relevant in this setting. And this is why trabecular bone score, TBS, a marker of bone trabecular microarchitecture, may have a better role in the assessment of fragility fracture risks as compared to BMD alone. An impairment of bone quality was actually confirmed in studies performing PQCT, where a significantly increased area and increased porosity of cortical bones can be observed. Fragility fractures are highly prevalent in patients with Cushing disease, affecting principally the thoracolumbar spine. Almost half of all the patients experience fractures, reflecting the significant involvement of vertebra. Serum cortisol levels after Nugent and Liddle tests, as well as ACTH suppression, were determinants of fracture risks. Moreover, regarding the incidence of fractures, this Italian study showed the significant role of low TBS together with previous fractures in predicting new fractures once. Moreover, note that the detrimental effect of hypercortisolism on bone is actually reversible, and after the cure of our patient, we can expect a significant increase in BND in most, but not all the patients. So far, for our daily clinical practice, we suggest to perform both DEXA scans and vertebral morphometry at diagnosis of Cushing. In case of normal parameters, we can follow up with DEXA scan. In case of osteoporosis without fractures, we need to monitor DEXA and evaluate the prescription of any anti-osteoporotic drugs in those patients already with vertebral fractures or in those where a reduction in T-score in DEXA scans are observed. And let's move to acromegaly. We all know that growth hormone play a key role in the longitudinal growth during puberty. However, at the same time, it is essential for skeletal health during adulthood, and this becomes much more evident when GH is in excess, as we can see in acromegaly patients. From the physiopathological point of view, we have learned that GH significantly affects bone turnover markers. And in acromegaly patients, many different studies showed a pronounced increase in both neoformation and resorption turnover markers, where bone resorption is increased more than neoformation. In the daily clinical practice, we know that DEXA represents the gold standard to estimate the risk of osteoporosis in postmenopausal women. However, in this specific context, many studies fail to demonstrate a significant impairment in bone mineral density, and actually osteoporosis, as defined by a T-score below minus 2.5 standard deviation, occurs only in a minority of patients affected by acromegaly. So, is osteoporosis really a concern in acromegaly patients? Let's move to bone microarchitecture, and we can see that recent studies highlighted on the possible impairment in trabecular structure. Indeed, TBS in acromegaly patients is significantly lower and does not correlate to bone mineral density as compared to healthy controls. Nowadays, an interesting tool for microarchitecture evaluation is represented by cone beam CT. As you can notice here from our study, there are significant differences in trabecular bone in acromegaly patients with increased space between trabeculae and reduced size of trabeculae themselves. At the same time, acromegaly patients with vertebral fractures had a significant impairment also in cortical bones as compared to non-fractured ones. We were the first group to publish a very high prevalence of morphometric vertebral fractures in postmenopausal women. Those fractures were not associated with low bone mineral density, but with active disease. And so acromegaly women with active disease experience a significantly higher frequent vertebral fractures. And then A couple of years later, we confirmed this finding also in men, observing an association between vertebral fractures and patient gonadal status. Since then, a series of cross-sectional studies validated our results, and in the subsequent years, we proved a high incidence of vertebral fractures in this clinical setting. And once again, also the incidence was strictly related to disease control. Surprisingly, in cured or controlled acromegaly patients, the presence of previous vertebral fractures and hypogonadism were associated with the onset of new morphometric fractures. Based on all these data, fragility fractures and specifically vertebral fractures have been recently recognized as a relevant comorbidity in acromegaly. And recent consensus tackled the correct approach to skeletal complication in these patients, recommending performing DEXA scan and vertebral fracture assessment every 1 to 2 years. So, in our daily clinical management, we recommend performing a vertebral morphometry at diagnosis together with the evaluation of bone quality and bone turnover markers. In case of no detrimental effects of GH excess, we can follow up with DEXA scan and check for morphometry in all those patients with untreated hypogonadism, reduction in bone mineral density, or active disease. Of course, we will keep on assessing vertebral morphometry in already fractured patients, and we should probably consider optimizing the biochemical control in those with active disease or evaluate the introduction of anti-osteoporotic drugs. And so in conclusion, we have observed that both acromegaly and Cushing disease are burdened by a very high number of fragility and in particular vertebral fractures. These fractures are determined by an impairment of both trabecular and cortical bone. And in this setting, BMD is poorly predictive for fracture risk, and morphometry remain a clinical need. The disease control and the early diagnosis still represents primary endpoints for the clinician, prescribing the most appropriate medical therapies. Taking into account also the complexity of acromegaly and Cushing disease management and the need for personalized approaches, we think that it is obvious that a bone specialist should be always included in the pituitary tumor centers of excellence. And I thank all of you for the attention.